Okay. Hello, everyone, and welcome to another TP Recap episode. My name is Ibrahim Omer. I'm a medical student from Sudan who is currently based in Saudi Arabia. Today, I'm joined by my very dear friends, Himun, Valeria, as well as Mariana, who will introduce us to three topics that they have done phenomenal research on. I guess I'll give them the space to introduce themselves, and we'll be starting first with Himon today. So Himon, the stage is yours. Please introduce yourself and share your presentation with the audience.
Yes, hi, my name is Himon. I'm IMZ from Korea. It's really, I'm so excited to present this case. It's going to be fun.
So Himon, I just made you a co-host,
Okay.
so you should be able to share your screen.
Sure. Okay. Can you see it? Okay, so today's case was on June 11, 24th. Case presenter was Ian Mines, and case discussed were Ravi and Yasmin. Okay, so the case was about sickle cell disease. I'm going to talk about the patient case later on, but sickle cell disease has a lot of variants. Today, I'm going to talk about sickle cell anemia and sickle cell trait and hemoglobin SC disease. So I'm going to give you three cases. Please let me know what is, belong to this disease. So age 10, splenomegaly, splenic laceration, at the end asplenia, back pain, vascular necrosis, and pulmonary infarct, pulmonary embolism, and all happening always like when the person is breathing high altitude or less oxygen. What kind of disease are you thinking of? And second case, age 38, usually happening athletic, mainly focus on kidney, renal medulla, ischemia, hypotenuria, because renal is not functioning. It cannot concentrate urine, so hypotenuria and microscopic hematuria. And also like visiting high altitude. Okay, and three case, the last one, age 55, splenomegaly, splenic laceration, back pain, vascular necrosis, pneumonia, and also high altitude visit. What will be this? If you know, if you can guess, please write down on the chat. All right. The first case was sickle cell anemia, homozygous hemoglobin SS, usually composed of hemoglobin S 90 to 100%. Severe symptoms can be seen hemolysis, vaso-occlusive crisis, and small sickle cell, target cell, Jolly bodies. And sickle cell trait, it's a heterozygous. Hemoglobin A is 55%, and hemoglobin S is 43%. Usually when you have a sickle cell symptom, you have to have a more than like 60%. In normal condition, no sickling, only extreme condition, renal medullary infarct and hypotenuria. You usually can see target cell but no sickle cells, and MCB is normocytic. Hemoglobin SC disease is S and C is half-half, like 50% and 50%. Mild hemolysis and vaso-occlusive only in extreme conditions. And this one is compared to sickle cell anemia, it is microcytic, highly related with thalassemia, iron deficiency, or chronic inflammation. I'm going to show this PBS in next picture. So like HBSC, the polychromasia is immature red blood cell, usually happening hemolytic anemia, and target cell post-splenectomy or hemoglobin C disease, you can see it, and how Jolly body is nuclear remnant. It's cleaned by a spleen, but if spleen is reduced, it's not going to do its job. So, and poikilocytosis is 10% or more abnormal shaped red blood cells. So like could be a target cell, teardrop cell, or bird cell, or sickle cell. And anisocytosis is higher variability size in RBC. So you can see all this in a hemoglobin SC disease. So let's talk about sickle cell disease pathophysiology. So hemoglobin SS, sickle cell anemia is glutamic acid. This one is hydrophilic, but this is hydrophobic, right? And this one is happening usually just soluble, but if oxygen presence, there's no sickling, but oxygen is absent, it does polymerize, it makes fiber. When does it happen? It happens when you have a reduced oxygen, dehydration, high altitude, cold, or extremely high temperature, or acidosis can cause this sickling exacerbate. And then dehydration, increased hemoglobin concentration, it exacerbates sickling. And the hemoglobin SC is not volume, it is lysine. When when it's dehydrated, when hemoglobin C is a lot, it causes crystallization. When you have a crystallization, it can cause hyperviscosity. And then if it is a dehydrated or deoxygen state, it increases hemoglobin S, the proportion. So it can also cause polymerization and hemolysis and sickling. So when you have this kind of things, what kind of symptom can you have? Extravascular hemolysis, right? Anemia, hemoglobin, sickle cell anemia, it's really like in severe case, you can have hemoglobin 5 to 8, but usually hemoglobin SC is mild. It's always more than 8, mild anemia, like could be 11 or yeah, it's very mild anemia. And MCV, normocytic for sickle cell anemia, and SC disease, microcytic. And you can see jaundice and splenomegaly and pigment gallstone too. And the vaso-occlusive crisis, stroke can be seen in children, so hemoglobin SS and proliferative retinopathy. And acute chest syndrome is like pulmonary infarct, so lung is very vulnerable, so it can have a pneumonia or it can increase pulmonary hypertension. And sickle cell disease has a hypercoagulability because endothelial function is not really stable, so a lot of inflammation too, so can cause hypercoagulability, so pulmonary embolism. And fat embolism is also the main cause of acute chest syndrome. And when you have the spleen is infarct or splenomegaly, you can have autosplenectomy. And renal medulla is very vulnerable, so you can have a renal papillary necrosis. And the mesentery ischemia can happen, so chronic abdominal pain, a vascular necrosis, femoral head, and osteomyelitis like salmonella infection. All these can happen with the HBSS and HBSC. And tropism or dactylitis is mainly happening children and young people. So a plastic crisis is like bone marrow is stop producing red blood cell. It usually happens because of parvo B19. These are usually happening in hemoglobin SS. Yeah, so let's go back to our patient. Our patient was a 55 years old male, left side abdominal pain for 3 weeks, and visited Mexico high altitude. And the symptom was left upper quadrant pain on palpitation and inhalation. So these are related to splenomegaly, and the high altitude caused the making hemoglobin S polymerization and dehydration, right? And jaundice can be caused by hemolysis, and a vascular necrosis of the femoral head is a vaso-occlusive symptom. Pneumonia can be the cause of acute chest pain syndrome. And low back pain is when you have the bone can be widening when the marrow has increased activity. And cholecystectomy can happen with a pigment stone. Yeah, and then the splenic laceration. And hemoglobin is not really severe, it's 11.3, and MCV is microcytic. And yeah, bilirubin 3.2. And because of the bone pain, alkaline phosphatase was 279. And LDH and haptoglobin could be caused by the hemolysis. And D dimer is 3,901 because this sickle cell disease have a risk of deep vein thrombosis or pulmonary embolism because of hypercoagulability. So blood smell, I explained it to you guys, so you guys remember that. So what will be diagnosis? So we talk about this sickle cell screen is the sodium metabisulfite is like it reduces oxygen tension inducing sickle cell, but we usually use gel electrophoresis. So the patient hemoglobin electrophoresis shows hemoglobin C at 43.6 and hemoglobin S as 51.2. Yeah, so it was diagnosed as hemoglobin SC disease. And management for hemoglobin SC or sickle cell trait, if it is asymptomatic, no need to treat. Folic acid or iron supplementation, hydration, or preventive management to be there. And management for sickle cell crisis, hydration, and morphine, careful on itching, constipation, central depression, because respiratory is decreased. So use incentive spirometry to prevent atelectasis. And DVT prophylaxis could be prepared, reduce hypocoagulability, and oxygen therapy, hydroxyurea. Don't forget the pregnancy test if the patient is a female, and blood transfusion and prophylaxis for penicillin and vaccination can be used. Yeah, and this is my reference, and yeah, this was the case.
Thank you so much, Himun, for this amazing presentation. And for those of you who are actually not aware, you may have seen some of the images that Himun had shown during her presentation. Those are images that she prepared herself. And so you can imagine how much time she took, not only to understand the subject, but also to present it very well and make sure that all of the graphics that are presented were prepared by her. So thank you so much for all the effort that you've put in towards this presentation, Himun. And with that, we're going to move on to our second presenter for the day, who's going to be Valeria. So Valeria, please, I've made you co-host, so you should be able to share your screen. But please make sure to introduce yourself to the audience.
Thank you, Ibrahim. Hi, everyone. I'm Vale. I am a recently graduate doctor here in Peru, and I'm going to present to you my teaching points recap. I'm going to stop my video just because my Wi-Fi is a little flaky. Okay. Can you see my screen? Okay, perfect. So today's teaching point recap by me, it's funny because the person that discussed was Mariana, and she's doing another recap as well. It's the VMR from the 13th of June, and it was a case presented by Han, who is a physician that joined us from Vietnam. So to start, what can you expect from this presentation? First, we're going to summarize the case itself, and then we're going to start with the first question, which is going to be, what should we do when we suspect acute meningitis? We're going to jump into the CT before LP dilemma, which is, an open conversation. I would love to know your thoughts as well. Then the second question is going to be, can meningitis involve the optic nerve, which was a characteristic that really caught our attention on this case in particular. And we're going to finish with thoughts on culture negative CSF bacterial meningitis and the illness script for Streptococcus suis meningitis. So this is the summary of the case. Han brought us the case of a 50-year-old male with chronic alcohol use that presented with acute loss of consciousness, severe headache, fever, deafness, and vision loss. His brain CT showed a thickened dura, a fluid level in lateral ventricles, and the lumbar puncture revealed neutrophilic leukocytosis, high protein, and low glucose. But the CSF gram stain and culture were negative. And this is a patient from Vietnam. So let's jump into what should we do when we suspect acute meningitis. And first, we should know that meningitis is a neurologic emergency, so we should treat it as such. Complications go from death if we don't do anything or if we take a long time to start antibiotics, to the most common one being hearing loss. So what should we do when we suspect acute meningitis? The first step is to draw blood cultures. This is because even though we can get a more direct sample through a lumbar puncture, this is a a diagnostic technique that can have some contraindications, as we're going to see in the next point. And blood cultures, as bacterial meningitis or acute meningitis is usually a systemic infection, tend to be positive and are a minimally invasive procedure that can also allow us to maintain antibiotic stewardship to know exactly what type of antibiotic we should give this patient. And in the first step, we should also rule out other system involvement, meaning if the infection is coming primarily from the CNS or is coming from another place. And I just wanted to emphasize this point, the fact that the studies show that a delay of something as little as 2 hours of starting antibiotic therapy can lead to doubling of the mortality. So this is indeed a neurologic emergency. And the second step is starting the therapy itself. And the base of therapy is to cover for bacterial meningitis, which is the most fulminant, one of the most fulminant types of acute meningitis that we can have. And for this, we should start with ceftriaxone and vancomycin, depending on the percentage of Streptococcus pneumonia resistant to ceftriaxone in your local hospital. Hopefully you have a study that will show if it's more than 10% or not. But either way, it's usually recommended to start broad and cover these resistant strains than just than not, and then the patient can deteriorate. Acyclovir is another indication that can happen if the patient has signs of encephalitis or mucosal or skin lesions suggestive of herpes virus. And for patients that are immunocompromised, are older than 60 years of age, or have a history of alcohol consumption, starting ampicillin is also recommended. And the studies have shown that steroids are good to reduce mortality and also the complication of deafness for patients that have Streptococcus pneumonia meningitis. However, because it is the most common etiology of meningitis, it's usually started as well with empiric therapy. And yeah, just wanted to emphasize this, even though, sometimes we are afraid that we're going to have a negative culture or negative gram stain on CSF if we start empiric therapy, we still have, for most bacteria, a 4-hour window in which the CSF is going to persist positive. After this 4-hour window, the possibility that we're going to find a negative culture increases. And the caveat here is that some bacteria or CSF sterilizes after 30 minutes, such as Neisseria. So we should keep that in mind. And then the first step is the question, should we do a plumber puncture or a brain CT first? And for this part, we're going to dive in the CT before LP dilemma, which is, an open question. We really don't have an answer, because the first paper that kind of established the clinical signs that will make us doubt if an LP is safe was this paper from 2001 that showed these signs: papilledema, unconsciousness or altered mental status, a neurologic focality if the patient is immunocompromised or older than 60 years of age, if they present with seizures or have a history of CNS disease. These are signs that could increase the risk of our patient of herniation, which is the complication of LP that we are most afraid of. However, okay, if this patient has these clinical signs, we should do a CT, right? What should we expect to see on a CT to make us think, okay, we're not going to do an LP? And this is a graphic that Dr. Casey Alvin gave me the permission to share with you today. If we don't see the sulci, if the sulci are obliterated, this means that there's a very high intracranial pressure. If the midbrain looks like a heart, which means that oh my God, I forgot the name of that. But like the spaces between the brainstem and the ventricle are totally obliterated. If you don't see them, if you don't see the cisterns, sorry, if you don't see the cisterns, that means that there's a lot of intracranial pressure. So, which means that the patient is increased risk of herniation. The same thing if you see a posterior fossa mass, it's the same. If you see midline shift that is significant, or one of the ventricles is entrapped, this should also make you think that an LP is very dangerous. But these are very dramatic signs of increased intracranial pressure. Most patients don't have these signs. And this is one of the limitations of this paper, because patients that have a normal CT can, still have very high ICP, can still be in risk of herniation. And patients that have ICP may herniate anyway, even if we don't do an LP. So are we really decreasing the risk if we don't do an LP? And a CT can really give us the tranquility that our patient is not going to herniate if we do an LP. So because of this, each patient is an individual decision. And I wanted to highlight here a paper that actually Aaron, the leader of NeuroVMR, wrote about a case that he encountered in which the patient presented with deteriorating altered mental status and a normal CT. And the normal CT made his team decide to do an LP, and the patient herniated. So as the CT, even though it was normal, really didn't help them to realize that this patient was in impending herniation risk. And also this systemic analysis show that there's some clinical signs of impending herniation that I wanted to highlight here: deteriorating level of consciousness, brainstem signs, and very recent seizures. So if we have these signs, maybe even if we have a CT, we should not go, even if we have a normal CT, we should not consider doing an LP. Because also we have seen studies, and this is not conclusive at all, but we have seen studies that show that even if we don't do an LP and we give empiric treatment for meningitis, we still have good outcomes in mortality and prognosis. And then the next point I wanted to highlight was that this patient had visual loss. So Ravi raised the question, can meningitis involve the optic nerve, explaining this visual loss? And yes, it can. I found some case reports of this in different organisms that can cause visual loss through optic neuropathy. And we should remember that optic neuropathy, they are not always inflammatory. They can be compressive, for example, in increasing intracranial pressure. And a great example of this is in Cryptococcus meningitis, as well as tuberculosis. And in general, meningitis can be very, very inflammatory. Also direct infiltration through the corneal plexus or hematogenous infiltration, and ischemia as well, because some organisms can cause vasculopathy, such as herpes, such as tuberculosis, which can lead to the ischemic neuropathy. And also the hypersensitivity of some medications, such as the ethambutol, for example, for tuberculosis, that can cause optic nerve injury. And then to finish, I wanted to highlight kind of a challenge of this case, that the patient had a negative culture, even though they had very high neutrophilic pleocytosis. And the point here was that even though they had a negative BRAM and a negative CSF, we should still have a high suspicion for bacterial meningitis, because it can happen. And the first cause, it is antibiotic use previous to drawing the cultures. But we can also have culture negative organisms that can present with neutrophilic pleocytosis. The first one being in the bacteria bucket, which is tuberculosis, which is an atypical bacteria. Then we can have fungi, amoebas, and viral etiologies as well. And here I wanted to share what are the diagnostic tests that we should ask for each of them. But in the typical category, this case brought us a new etiology that we should consider, especially if our patient has risk factors. And for this, we should talk about Strep suis. Strep suis is a bacteria, a gram-positive bacteria that is very prevalent in Vietnam and in Southeast Asia. And the risk factors include exposure or injuries by pigs. And this patient had a history that they were a farmer and they also were from Vietnam. And also alcohol consumption has been shown to be a risk factor. And the most common presentation is indeed meningitis, which presents most commonly with altered mental status. The triad of meningitis is rare, and the clinical kind of clue that can lead us to think about a Strep suis in the right epidemiological setting is if the patient presents with hearing loss. So a patient that presents with hearing loss and has history of being contacted by pigs, and we are in Vietnam or in Southeast Asia, we should think about a Strep suis, even if they don't have fever, even if they don't have headache, because it's a very rapidly progressive bacteria. They can have severe sepsis due to this, their high virulence. And well, I wanted to share that they can have some skin manifestations as well and ocular involvement, but not of the type that we saw in this patient. And to finish, just to highlight that this is for me a new bacteria that I should consider in culture negative meningitis, because even though it is a gram-positive cocci, it is usually not, it usually doesn't grow even in the common setting that it should. but also most times it's misclassified as another streptococcus. So usually it is only found that it's a strep suis through molecular identification. And for the treatment, thankfully, it responds very well to the usual bacterial meningitis coverage, ceftriaxone and vancomycin. And what is interesting about this is because this bacteria presents typically with deafness, which is one of the things that steroids really help in the studies that have shown decreased deafness in the long term for strep pneumo. So should we extrapolate these results for this bacteria as well? And the answer, sorry, is that we really don't know because there are not enough studies. But the ITSA guidelines suggest in patients from Vietnam and Southeast Asia to start steroids as well if they have this criteria here because of the high suspicion and high prevalence of strep suis. So yeah, that's my presentation. If you have any questions or thoughts about the discussion, I would love to hear them. Thank you.
Thank you so much for this awesome presentation, Valeria. And for those of you who don't know, we actually just had a neuro VMR, and Valeria was the person who delivered the TPs during the neuro VMR. She did not get to read them out loud because we were short on time, but she jumped immediately from the neuro VMR to today's TP recap VMR. So thank you so much for the wonderful presentation of today's case, Valeria. I can't say anything more. I guess the chat really says a lot about your presentation already. And so now we're going to move to our last but not least presenter for the day. Mariana, please feel free to share your screen and introduce yourself to the audience.
Hello, everyone. I'm Mariana. I'm one of the SIP Silvers team members, and I am Brazilian medical graduate, and I'm very happy to be here today to present this case for you. So please let me know if you can see my screen. I'm starting to share it right now. Were you able to see my screen?
No, maybe you could try again.
Okay. I think I won't be able to present in full screen, but let me try again. I'm sorry. What is technical problem? What about now?
Yes, we can see your screen now.
Oh, okay, thank you. So I'm going to do an overview of the case presented by Luki, Mailey, and discussed by Rabi and Reza on June 14th. I wanted to bring this case as an overview because it really fascinated me the way that it was discussed and also the clinical reason behind everything that was being done for this patient. So that's why I chose it. So let's start it. So as HPI, we had a 52-year-old male who was in his usual state of health until 4 weeks before the presentation. And then he started to complain of progressive shortness of breath on exertion. And he was so short of breath that he had to crawl up the stairs from a baseline from being able to walk multiple blocks. And only with this pace of data, we can know two main informations here. The first one is the subacute nature of the disease that is appearing for 4 weeks. And the second one is how dramatic it is because the patient could walk and now he has to crawl up the stairs. And just to warm up a little bit, I would like to ask you all, which of these conditions would be less likely in the context of a subacute dyspnea? And you can put your answers in the chat. So we can discuss a little bit about that. So just for the sake of time, I'll go ahead. But we would expect that asthma wouldn't appear in a subacute presentation like that because we would have either a chronic presentation or episodic flares. So among the options, among the options, asthma would be the less likely in this scenario. But it's just too early to talk about diagnosis. And the most important thing, and the first step, is always to have a broad differential diagnosis, and also to think systematically about everything. So it may be easy to associate dyspnea to a pulmonary injury, but we have to keep our differentials broad. So we have to think about cardiovascular issues. We also have to think about chest wall injuries, or even neuromuscular, or even conditions such as acidosis or thyroid storm that could be contributing to this symptom. And I really like this Tipsover's schema because I think it highlights really well this part of thinking broadly. Okay, so continue with the HPI. The patient also noted lower extremity swelling and worsening dyspnea when lying down over the same period of time. And he also mentioned that his abdomen was so swollen that he could not see his feet anymore. So with that in mind, we start to think about a fluid overload. And as soon as we think about fluid overload, we have to consider damage in the heart, in the liver, and in the kidneys. And it's very easy, again, to associate fluid overload causing direct shortness of breath. And it can be easy to blame the heart for all of that. But it's important to keep in mind that we still can't rule out liver and kidney disease in this condition. And to make us even more curious, the patient also mentioned dark urine. And again, we can think that dark urine may be a sign that the liver or the kidneys are damaged. But before doing that, we have to take a step back and think, is this dark urine a noise or a signal? Because we have benign conditions such as hemoconcentration due to poor fluid intake that could be causing dark urine without it being a real issue. And of course, we're gonna confirm if the dark urine is really a signal once we have labs and urinalysis, for example. But before that, we can use one of the best friends of the internal medicine, and that is the physical exam, and try to see if the patient has any signs of jaundice or icteric sclera, because it could be a sign that there is a liver issue. And in this context, with a liver issue, we could have ascites with compressive symptoms in orthopnea, or we could have nephrotic and nephritic syndrome causing dark urine and fluid overload. So, and another important thing to consider here is that we can, it's very important to consider that we can have like associated symptoms and associated damage in the heart and also in the liver, but also we could have a connection between the liver and the kidney, or even the heart and the kidney, or even the three of them. So at this point, we still need more data to try to find out what is going on, and we should not focus on blaming one of the organs. And moving on with the physical exam, we had a blood pressure of 203/91, and icteric sclera and mild crackles at lung bases, and also a 4+ lower extremity edema. And in the labs, it was possible to notice that we had a hemoglobin of 8.3 with undetectable haptoglobin, increased LDH and bilirubin. And with that, we had a clear pattern of hemolysis. So this is the first thing that we can conclude here, that we had hemolysis. And for hemolysis, there are a lot of reasons for hemolytic anemia. We can have like infections, or even enzymes deficiencies, or autoimmune conditions. And one important diagnostic tool to know what is going on is the blood smear. And for this patient, we were informed that they could see spherocytes in the blood smear, and also DAT was positive for EDD. So with that, we could diagnose autoimmune hemolytic anemia, specifically the warm type. But the autoimmune hemolytic anemia would not explain why this patient has such an important lower extremity edema. And again, we need more data and more labs to try to figure out what is going on. And then we had information that the BNP was greater than 6,000. TTE showed ejection fraction of 55% with elevated PSP and dilated ICV. We also had mildly elevated liver enzymes with CTAP showing hepatomegaly without biliary dilation. And kidney exams were pretty much normal. So at this point, we rule out a kidney issue here. We still can't rule out a liver disease, but it's not too important, the abnormalities that we can see here. But we certainly can blame the heart for a heart failure with preserved ejection fraction, considering the patterns that we see in the echocardiogram. So at this point, we had heart failure with preserved ejection fraction associated with autoimmune hemolytic anemia. And in order to try to find out what is really going on, we can further assess one of them and try to find out causes for that. And we know that there are a lot of causes for heart failure with preserved ejection fraction. So maybe a better idea would be to further work up for autoimmune hemolytic anemia. So for warm IHA, we would have half of the patients would have autoimmune hemolytic anemia due to idiopathic causes, and the other half can happen due to lymphoproliferative disease or autoimmune conditions or even immunodeficiencies, infections, and drugs. And until this point, it was not mentioned any drug that the patient had that could make us think about that, or not even an infection. But we still needed more exams to investigate for lymphoproliferative disease or autoimmune conditions, for example. So we had one more aliquot of workup, and the workup for infectious disease was pretty much negative. We only had IgG positive for EBV. That was not too relevant in this case. And we also had ANA positive, but for ANA, we would be thinking, especially in lupus and scleroderma, that would be very unlikely that these conditions appear without any kidney involvement. So it was not very relevant for us in this case. But we also saw that CT chest showed axillary lymphadenopathy, but the biopsy was not revealing. So at this point, treatment was started with glucocorticoids to treat the autoimmune hemolytic anemia and also diuretics for the heart failure, and the patient really got better with the treatment. So they were planning to repeat the scans once the patient was feeling better. But until this case was presented, we didn't have a final diagnosis. We could have autoimmune hemolytic anemia associated with heart failure or a lymphoproliferative disease that still need to be investigated, like deeper investigated. So why I wanted to bring up this case just to tell you guys that a clear final diagnosis is not always achievable, but it's very, very important to think about everything systematically, because in this thinking process, in the diagnostic process, you can find conditions that you can treat and that can make the patient feel better. So that's the importance of thinking critically and thinking systematically. And also special attention is required for conditions involving multiple systems or organs. These conditions are real clinical problems to be solved, and that's why I wanted to bring this case. I thought it would be fit really well with the VMR recap and also with the CP solvers. Thank you very much. Thank you, Luke, for this amazing case presentation, and Rabi and Reza for the brilliant discussion, and thank you all for watching my presentation.
Thank you so much for presenting this awesome case, Mariana. And also, once again, I feel like I've already said this for the past presenters, but you've also put in an incredible effort towards your presentation, even though you were just done with step 2. So congratulations on that, and congratulations on the amazing presentation today. And thank you to everyone who had been able to attend today's TP recap. And hopefully we can see you on our next TP recap happening in August. So see you guys soon, hopefully. Bye, everyone.